All right, you don't see that. Oh, Lord. Let's move that over here. All right, so I was going to start with just the duplex evaluation of the foot. So I'm just going to start off by saying Dopplering the foot, doing ultrasounds for the feet is very, very uncommon. So the likelihood of you guys actually doing this is going to be very, very low. But this is just something that we do need to cover for vascular for the board exams. And the main premise of this, we're focusing on a term called acceleration time. Specifically pedal acceleration time. So pedal referring to the foot. We're going to be assessing the speed at which the blood flow is accelerating, because this will help to determine whether or not, there is the presence of a stenosis or a blockage. So we had that term, tardus parvis waveforms. So this kind of ties into that tardus parvis waveforms. So what we're going to be measuring when we're doing these Dopplers for the foot is something called the acceleration time. So we have our arterial tracing, our arterial waveform. We're going to be measuring that time it takes for the blood flow to accelerate from the beginning of systole to that peak systole. So in order for us to measure that acceleration time, the machine has a function where we're going to place a caliper at the start of systole, and it's going to have this little dotted line that measures up the slope of that acceleration of our blood flow up to that peak systole. So we're basically measuring the slope or the rise time. The reason it's a time is because what the machine is really doing is measuring the time it takes to go from here to there. So this y-axis is actually a unit of time. So this is time. It's typically measured in microseconds. Actually, it's very fast. So to try to just go over some basic anatomy for the plantar foot. I don't like this view. Get out of here. There we go. So that posterior tibial artery that we followed down along behind the medial malleolus, it actually branches into or becomes a plantar artery, which then bifurcates into the medial plantar artery and the lateral plantar artery. So we have that posterior tibial artery coming down, becomes the plantar artery, which then splits into a medial along the inside of that foot, and then a lateral plantar artery along the more base of the foot in the arch. And then that lateral plantar artery then continues on and becomes the deep plantar artery. So at that point, it kind of dives deeper towards the dorsum of the foot or the top of the foot. And then we have the plantar metatarsal artery is another branch of that. So the actual exam itself, we're typically going to use, since these vessels are very close to the surface, a very high frequency transducer. So oftentimes we utilize the hockey stick, and we're going to be measuring our pedal acceleration times in these various arteries. So we're going to do the arcuate artery on the dorsal side of the foot, the medial plantar artery, the lateral plantar artery, and the deep plantar artery. Typically with this exam, we also obtain ankle brachial indexes as well as toe brachial indexes. So using our PVRSLP machine, we place those ankle cuffs, get an ABI. We use our little toe cuffs and our PPG sensors to calculate a toe brachial index. So we are actually getting those toe pressures. Here's an example of what it looks like when we're measuring that acceleration time. So again, we've just kind of placed that little caliper at the start of systole, and then it has a little dotted line that brings it up, and we're measuring along the slope of that rise time or that acceleration speed up to that peak systole. And then the machine calculates the amount of time it takes for that blood flow to accelerate from the beginning of systole up to peak systolic velocity. I was just showing them. So we measure, again, put the caliper here at the beginning of systole, and we just measure up along that slope to peak systole. So with this exam, there are some limitations. So if the patient, again, is diabetic, the walls of that artery become very calcified. So if they're calcified, it's hard for that sound waves, the ultrasound, I don't know whether to look at you or them, to penetrate through the vessel wall for us to be able to get those images. So we oftentimes wind up with shadowing in these vessels. There's a lot of variation in people's anatomy of the vessels when it comes to the foot, as well as variation in vessel sizes. So some people might have very, very teeny tiny vessels. So as you guys have seen when we're imaging the upper extremities, some people have very teeny tiny radial and ulnar arteries. So the same would hold true once we get down towards the foot as well. Some people can't tolerate anything touching the foot, particularly patients, might have some sort of diabetic, pain or issues, maybe neuropathy, or patients also might be very edematous. The foot might be very swollen, which might hinder visualization. Something to also consider too is if a patient has inflow disease. So we talked about, patients who have aortoiliac disease, they're going to have low pressures and low flow throughout the entire extremities. So that's going to affect, what we see down by the foot, particularly when we get down by the foot. So if, the patient has very slow flow and very low velocities, if they're less than 5 centimeters per second, these pedal acceleration times are considered inaccurate. So this is now on the top of the foot, that arcuate artery. So remember in lab when we were doing our PVR SLP exam and we were doing the dressage pedis artery, some of you, like when you were on the top of the foot, we had to actually invert that waveform. And we were trying to figure out why, I'm pointing up, does it make sense? Why am I inverting that waveform? It's because we were probably lower down on the dorsum of that foot, right when we were splitting into that arcuate and dorsalis metatarsal artery. So we got that splitting. So if you happen to be, insinuating and angling at this point, the blood flow is actually going away from away from that probe. So that's why we had to invert it. So you probably just had that bifurcation on the top of the foot. Which is fine because you're still going to get the same pressures because again, our pressures are coming from that ankle cuff. So this was again just showing now the measuring that acceleration time. So we measure, we do a measurement for the dorsalis pedis artery. We do the arcuate artery and the dorsal metatarsal artery, so that branching. And then we do follow the posterior tibial artery behind the medial malleolus until it bifurcates into that medial plantar artery. So the medial plantar artery is more superficial and smaller than that lateral plantar artery. So we kind of angling our transducer, rotating our transducer more medially along that course of that artery, and more lateral for that lateral plantar artery. And then we follow that lateral plantar artery along its course, and then it starts to dive deep and becomes the deep plantar artery. So lateral plantar artery eventually becomes the deep plantar artery. So I really don't, I'm not requiring you guys to memorize, this chart in terms of rise times. But one thing I do want you guys to just recognize is that as the the acceleration times increase, that represents more significant disease. So a normal acceleration time we have here between 20 and 120 milliseconds. Once we get into more significant disease, so we have claudication after more than 2 blocks, so the patient can walk more than 2 blocks, less than 2 blocks, and then critical limb ischemia is patients who have rest pain and tissue loss. So again, if we go back to our oh. It's all good.
Paper towel.
Yeah, I might just use a paper towel. So if we go back to our, our term tardius parvis, we said the tardius parvis waveforms happen after a stenosis or blockage. They represent people that have, peripheral arterial disease. So the longer, the more shallow that slope, the longer that rise time is going to be. So that time is going to be much longer, the more shallow that slope is, or the less steep that slope is. So the more tardish your waveform, the more significant the disease is going to be. So the boards will give you questions comparing acceleration time or rise time. Sometimes they call it rise time as well, but more commonly they're referred to as acceleration time or even acceleration index. So you can take that time and create an acceleration index based on the height of that waveform as well. So again, the longer the acceleration time, the more significant the disease. So you may not know what a normal acceleration time is for a particular disease segment or a limb, but they'll give you 2 numbers, one that is very, very small, and then one that's substantially larger. The larger one is the size or the extremity or the side that has disease. So they might tell you to pick between the right leg or left leg, as the extremity that has the potential disease just based on those acceleration times. So the longer or higher the acceleration time, the more significant the disease, and that's the side that has the disease, because in essence, they want you to recognize that acceleration time has to do with tardius parvis, with that delayed acceleration, and indicates the presence of disease. So that's the main takeaway that the board exams want you to understand and be able to kind of wrap your head around. So this was just showing some examples of case studies. And post-procedure, they went like pre-procedure, they were in the 250s, 300s along that plantar artery. And then post-procedure, the plantar artery improved to 130 milliseconds. So again, the likelihood of you guys actually doing ultrasounds for the foot is very, very rare. I mean, this might be something that's done if you're in a wound care center. It's typically not done in a hospital. I mean, in New York, we never really ultrasound the foot ever. Like if anything, we would do just the toe pressures And usually that was sufficient enough for the doctors. So the only thing I really want you guys to recognize or get out of this is just understanding, the whole premise of acceleration index or acceleration time.
What is the acceleration index like normal? Is it when it's over 120? Is that when it's?
Yes, so once it gets over 120, it becomes abnormal for the pedal acceleration time. Yep.
So the 20 to 120 would be normal?
Normal, yep. Let's. So now we're just gonna review again some analysis for our PVR SLP. So again, we said for the arms, we need, it has to be less than 20 millimeters of mercury difference between both arms. So if there is a difference greater than 20 millimeters of mercury between both arms, that indicates likelihood or the presence of some sort of arterial disease central. So subclavian arteries is going to be your most likely place. Could be axillary artery that's causing that low pressure on that one extremity. So if you do see a difference between the two arms, recheck. If there is truly a difference greater than 20 millimeters of mercury between both arms, the side that has the lower pressure is the side that has the disease segment, and it's always going to be a more central. So again, that disease segment has to be proximal to where you're taking that pressure measurement. Let's see if we can make this bigger. There we go. So let me see. Status post motor vehicle accident complains of intermittent pain and numbness in the forearm and hand and fingers. So all the pulses were graded high. Either 2 or +3. All the pressures, appear normal. Brachials are the same. Radial ulnar, everything, looks normal with the pressures. The waveforms all look normal. So this looks like a normal study. So just really looking at it, like if the only thing maybe you would have seen potentially is this first and fifth digit. The waveforms don't look as high amplitude as they do on the left side, but they do look normal within normal limits. Like, so you still have all the normal characteristics of the waveform, like dichotic notch, fast upstroke, sharp peaks. To improve the study, these gains could have been turned down for the digits. So they look, to improve that. So for this one, just another upper extremity study. So again, it's going to be really easy for you guys to tell the difference between normal and abnormal. So the waveform cuffs, we're getting, looks like a little bit of tracing in the upper arm, and then it really disappears once you get into that forearm. Since it disappeared and they were trying to insunnate through that radial artery, and they weren't able to hear anything or get any pulse, they weren't able to obtain any pressures on that right arm. They went up to the brachial artery below that cuff to try and see if they can insunnate as well. They weren't able to hear the brachial artery just below the level of that cuff as well. So they weren't able to get any pulses there as well. So this indicates, an probably occluded brachial artery. So this was a PBR-SLP done on a patient who has, they were questioning if the patient had subclavian steal syndrome because they were having symptoms, intermittent pain in both hands, greater on the right side. So they have a fistula in both arms. The AVF on the right side is the one that is patent and now being used. So when they obtained their pressures, they got lower pressures on that right side compared to the left. The waveforms look a little bit different. So we don't see presence of that dichrotic notch. So in order for us to, really diagnose if there was a subclavian steal syndrome, we'd have to see, with and without compression of that fistula to see if we get a difference in the waveforms. So we do lose a little bit of the dichrotic notch in this. So this is kind of a harder interpretation. So then they did the digital pressures, again, now with and without compression of that graft to see if there was any improvement. So without compression, they showed the digital pressures being very, very low. And then with compression, we see an increase in those pressures now on that right side. So since the patient is having symptoms, and we did see improvement of those pressures with graft compression, that would indicate the presence of that steal syndrome. So what's going on is that fistula is stealing the blood flow from going to the hand, creating slow flow or reduced flow going to that hand. So the interpretation for this study is it's just showing that the pressures, increase dramatically when we compress that fistula. So it was this fistula that was stealing the blood flow and creating those low pressures. Do you guys understand that, like the whole principle of like the steal syndrome?
I understood the concept, but I don't remember like
okay. That's how it works. Sure. Yeah. One diagram. All right. Oh, maybe just wait. Gotcha, must be my bad.
That's other you.
I need an eraser. Where's my eraser?
Do you need to get one?
I know. I always use that. Feels like air. Weird. Super light.
Is this something that's gonna be on the top of my
Understanding Steele syndrome. Yeah. Because we can have, it's going to help you too, because there's a condition called subclavian Steele syndrome.
Oh, yeah, where the. Sounds.
There we go. I'll give you guys a peek before. So we have a fistula, so we have that connection between the artery and the vein that's created. So blood flow, should be going down the extremity. But it's going to want to get diverted to the areas of lowest pressure. It's going to follow the path of least resistance. So a lot of that blood flow is going to enter into the vein, which is what we want with dialysis patients. So we want to create this high flow environment where the blood flow gets diverted directly into that venous system. So some blood flow should still continue down towards the hand, because we still need that. We also have, the ulnar artery, trying to help out as well, if we're utilizing the radial artery. So that should also be bringing blood flow down towards the hand. But again, some patients might have an incomplete palmar arch. That fistula might be too large or too strong, where it's drawing too much blood into the venous system and not enough blood flow is continuing down that radial artery towards the hand. And it might be so strong where it actually creates retrograde flow, where we might wind up with flow reversal going in the opposite direction, so actually stealing it from the hand. And that might lead to patient developing symptoms, pain, cramping, numbness, tingling. There could be cyanosis. It could be very cool to the touch, pallor. So, the symptoms could be very, very severe. It could even be limb threatening if it's severe enough, that steal, or if it's strong enough, that steal. So we're doing a test where we're actually temporarily just compressing that fistula to close it off and prevent blood flow from going into the venous system through the fistula, to see if that improves blood flow to the hand, or how significantly that improves blood flow to the hand. So if we see a dramatic increase or improvement in blood flow to the hand by compressing that fistula, we know that that's the cause of that patient's symptoms. So it's really based on the patient's symptoms and how they're presenting. So if they're not showing any symptoms and we still see, like if we're Dopplering and doing our ultrasound exam, and we Doppler that artery distal to that anastomosis, and we see retrograde flow, if they don't have any symptoms, that's fine. That's okay. We still document, there's flow reversal, but it doesn't constitute Steele syndrome because they're not exhibiting any symptoms. But, if the patient is there, they're experiencing symptoms, they're here for that reason, and then we compress and we see improvement, then we can say, yes, this patient's positive, for symptomatic Steele syndrome or Steele phenomenon.
What are some symptoms?
So all your arterial symptoms, so like, pain, cramping, claudication, so pain in the hand, cramping in the hand, discoloration, so it starts turning either bluish or purplish, like cyanotic, pallor, so paleness, So all those tingling, numbness, so any of those types of symptoms. So this chart, you can also, some places also break it down based on symptoms as well. So we have our normal range 0.9 to 1.3. Some labs will do, 0.8 or 0.5 to 0.8 as claudication, or essentially 0.9 to 0.5 is claudication. So just below that normal range. So it encompasses this mild peripheral arterial disease. So 0.9, 0.5 as claudication, then 0.5 to 0.3 as rest pain, and then less than 0.3 as like ischemic ulcers. So when the patient starts developing ulcers. So a 48-year-old female complains of cold feet and legs. History of back surgery. So she has a history of hypertension. So we could see that no, her pressures are okay. So she's probably on medications. But we could see that history of obesity, smoking, previous back surgery. So just looking at the ankle pressures, they're kind of high. As we move up the legs, the pressures go up. But looking at the waveforms, they all look like they're healthy, normal looking waveforms. So this could just be, a byproduct of just having her being obese and having a large limb size, that we're getting these high pressures, because all the waveforms are telling us, that everything looks normal in terms of the blood flow. So again, so those higher ABIs might be results of the patient's limb size. Again, so those are kind of the steps I just kind of want you going through. So like you can look, at your ankle brachial index first to determine, if there is presence of disease. So, these are on the high end of normal. But then if you then go look at your waveforms, all the waveforms look okay. So that's good. And then you can look for any pressure drops as well. So again, everything looks symmetric if you go linear or laterally, and then vertically. Again, you don't see any large pressure drops. Then comparing, again, now someone that has obvious significant disease. So again, go right to your ankle brachial index, abnormal bilaterally, it's lower on the left. And then you can compare your pressures. So looking for any large significant pressure drops between segments. So 120 to 115, no, 115 to 104, no, and then 104 down to 96 or 100, 101. So same thing on this side, you don't see any significant pressure drops greater than 30, but they're low, across all segments. So that means the disease, since it's bilateral, has to be, it could be aorta, just the aorta, or it could be both iliacs. We don't know. So we describe this as aortoiliac disease. What do you guys think about this one? I can make it harder.
No difference at all.
255 is not
All the way down.
yeah, so it's not compressible. So when you see 255, that means that. So that's a good example of a patient who's got medial calcinosis.
But how come the waveforms are different?
So it's not really 255. So this is the max I proposed. So they're showing that it's not compressible. So when you see 255 on a study, it'll either say not compressible or they'll just put in 255 to represent that they couldn't obtain the pressure because the vessel was not compressible. So on that left leg, since the pressures are non-compressible across the entire extremity, you really have to rely more on your Doppler waveform tracing to see if there, really is presence of stenosis or disease.
The other side, there's a really big drop. 171 to 143.
Yep.
So that's another sign of disease right there.
Yep. So this patient, and you can tell the waveform change too, like the amplitude. So when we went from cap down to ankle, there's a pretty significant drop. I like the amplitude of that waveform. They didn't do brachial pressures. Oh. Yeah.
Medial aspect of right calf. That's it.
Medial aspect of right calf. Yeah.
So at that point, how would she eventually become the lighting to it?
For this?
Well, it's not compressible though.
When it's so high pressures are better than low pressures.
That means there's at least something. Yeah.
Yeah, so there's pressure in that vessel that's getting blood flow down the leg. So even though it's not compressible, it's because of her diabetes that have calcified that artery. So the walls of that artery are very calcified, but there's still blood flow getting through. So we still have decent looking. Remember these waveforms measure volume of blood flow, so it's pulse volume recording. So the volume of the blood flow getting through is not bad. We still have normal looking characteristics. We still see a dichrotic notch. It's a fairly fast upstroke. It's not, some of the ones that we saw previously, like the guy before, where, these are really flat, particularly down at the metatarsal completely flat. So these are, obviously unhealthy looking waveforms. They're very targus parvis, like slow upstroke, very low amplitude. We've lost a lot of those healthy looking characteristics compared to something like that. So these waveforms look relatively healthy, even though we get a pretty significant, drop in amplitude, between those segments, and we also demonstrate a pressure drop. These pressures aren't going to be necessarily accurate because of those, that medial calcinosis. So the right leg does have some sort of disease going on. We don't have that brachial pressure to compare it to. But if we were a doctor looking at it, they probably do have sufficient enough blood flow to be able to heal that wound just based on what the waveforms look like. So, I mean, these aren't, even though they're smaller in amplitude, they're not terrible looking. Someone's a little bit tricky. But, we would want you to recognize, that this side, this patient, or recognize that this patient has medial calcinosis, because of their diabetes, that this side is all not compressible. So then that's probably the disease that the boards would want you to recognize the presence of that medial calcinosis.
Wait, so the tops are non-compressible, and how are the bottom, I'm confused on that, how are the bottoms compressible then?
How are the bottoms compressible?
Yeah. Like, if it's already calcified, calcinosis, like, the calcinosis at the top, then how, can you explain that to someone? On how it's compressible at the bottom if it's not at the top? Or is it compressible?
No, it's not a silly question. So, like we said, the pressures typically go up as we go up the leg. So the pressures are like they're calcified uniformly, but it's still easier to compress these vessels down here, even if they are heavily calcified.
So they're just fully.
Yeah, they're just,
Calcified at the top.
well,
Fully
I don't want to say
non-compressible.
fully calcified, but like,
Fully non-compressible.
Yeah.
But then not.
yeah, and it also probably maybe has to do with limb size as well. But
The ABI is still like.
yeah, because they're hypertensive as well. So I mean, it's that upper range of normal, but this patient definitely has medial calcinosis.
So that's all we would have to say, or what else would we need to identify?
Patient likely is suffering from medial calcinosis, or in a preliminary report when if we were writing this up in the lab, we would say bilateral ankle pressures are falsely elevated due to the presence of medial calcinosis. And then we would say, like bilateral calf, low thigh, high thigh segments are non-compressible.
And then pretty much all we would identify.
So this is the way so SLP non-compressible except for ankle levels. You report the ankle brachial indexes for the right and left side. You would say, there's really no evidence of significant peripheral arterial disease. So just because they're calcified doesn't mean it's preventing the blood flow from getting through. So that's the other thing you have to kind of remember. Like just because the walls of the vessel are calcified, there's still blood flow getting through. So they still have perfusion going down to the leg, as evident by our pulse volume waveform. So we still have, fairly healthy looking, pulse volume waveform. So definitely see dicrotic notch by the ankle. So these look normal, especially down at the ankle and metatarsal.
So the drop right there, the 255 to like 200, like 208, like that's kind of negligible since we have that medial calcinosis at the top. We wouldn't consider that as a major pressure. Yeah.
So when the patient has medial calcinosis, pressures go out the window. You really can't rely on pressures anymore. Yeah. So you have to go based on your waveforms. The waveforms, yes. So this was another patient now. So again, medial calcinosis, both sides. Left side, we weren't able to obtain any sort of ankle pressure because it was not compressible down at the ankle. On the left side, I'm sorry, on the right side, we did get an ankle pressure, but you see it's very elevated. Those metatarsal waveforms, slightly lower amplitude on the right metatarsal than compared to the left. So there might be the starting stages of development, maybe some small vessel disease potentially, just because of the amplitude of those waveforms is different. That might be looking a little too much into it.
still here, could we say that there's, even though like the tops are non-compressible, we drop, but that drop after, wouldn't that be significant? Or it doesn't matter at all if we're going to do the
Yeah, so this one's a little more confusing. So you see, you're right, you see a pressure drop going from high thigh to low thigh.
Yeah.
But you also have to look at the waveforms now. So high thigh to low thigh, I don't see any, major change in my waveform going from high thigh to low thigh. So if I'm going to have a pressure drop, there's going to be a change in your PVR waveform. So this patient might just have really large thighs. So it might just be a body habitus thing that high thighs are non-compressible.
So you wouldn't write medial compressible. For the top part, there's non-compressible. Is it all?
You're confused. So medial calcinosis is when you have elevated ankle pressures. Like the ankle pressures have to be elevated too, and it's going to be elevated typically across all segments.
But our ankle waveforms at the bottom.
Oh, going the wrong way.
Wait, yeah, this one. Oh wait. Oh yeah, that was one. Yeah, what is it?
Oh, but we do, I'm sorry, there was a drop from. Yeah, so there was a drop from, the drop from the high thighs to the low.
That's what I'm saying.
And then the low thigh to the calf.
Yeah, is that still significant though, because it's already kind of. Like we already have the initial drop from the medial calcinosis, and then after that big drop, would that be accurate to say there's a chance for disease? Because we've already kind of dropped from that not compressible before.
Yeah, it's a bad example. Yeah, so I mean, you could question, the presence of disease going from 199 to 161.
But on the same side.
At the same time. Yeah, we have similar on that side as well. But the waveform doesn't change that drastically. We don't.
So it would be questionable what we can't say.
But yes. The left calf is like doesn't have a dipole much. Or does it? I can't really see.
There's one here, like on this end.
Yeah, I see it.
It's just a bad waveform. It's because it's going off the chart.
They should have
adjust that, yeah. So based on SLP results, PVR waveforms may be showing good collateral flow. PVR waveforms all appear normal. Based on ABI, is it normal? Yeah. So this is a tough case study. So this would be something like you just report your preliminary findings,
With the doctor figure.
Yeah. So this is definitely obvious.
Yeah. Well, wait, how is it zero across it? Oh, wait, they didn't do pressure on that part. Wait, why is there nothing at all for the right eye and one thigh? Does that mean there's usually something there that they couldn't take the pressure for?
Yep. So once they got down to the ankle, they got flat waveforms. So there was really nothing from that ankle down to the foot, like no blood flow.
Well, why did they take a high and one thigh and calf on the right? Pressure. Why is there no numbers? On the other side.
What?
The right side didn't do anything, they didn't even try.
They didn't even try.
The brachials are fine.
Yeah, brachials are good.
No. Immediately.
So they probably tried to maybe insinate higher up to try and get those. Or you could maybe go to popliteal and get the thighs. They have no blood flow from the ankles down. So the calf, we were getting little waveforms.
So why does it zero? That's the pressure.
Yeah, they just.
That's what's starting out.
So it's moving so fast. What are they like not able to do?
Yeah, because they couldn't get any, they couldn't hear the dorsalis pedis or the posterior tubular arteries on either side. So that's why it's no pressures. Yeah, it's silly that they have it on this side and not on that side as well.
Yeah.
It's a little confusing. You know, if this were me, I would come to popliteal artery. Since I'm getting a waveform at the calf level, there's got to be some blood flow getting to that calf cuff. So I would try and come to the popliteal artery and at least try and obtain pressures for the low thigh and the high thigh. Oh, that's the wrong patient. So in this case, like I can come, you know, to that popliteal artery, put my probe there, try and find the artery, and at least get pressures in these two segments.
So it's well disease basically.
Yeah, it looks like there's.
So you got disease up here, and then the second level of disease, obviously, between the calf and the ankle.
Yeah, so it's definitely disease like bilateral aortoiliac.
And then again, there's also.
Is there gonna be an inclusion by the ankle because there's no blood flow?
Yes, so from here down, the arteries completely occluded. There's no blood flow.
On both sides, though.
On both sides, yeah.
And then there would be, like, there could be disease at the top too, right? Like by the aorta.
Yeah, so there's.
Like multi-level.
Yes, multi-level disease, definitely, because these aren't normal looking, they already look like they're.
Same thing.
Yeah, and they're kind of abnormal looking. And then it just gets worse. From there to there, and then really bad. So it's bad to worse to terrible.
Have you ultrasound like somebody when it's included?
Yeah, so like if I did my PVR first, like, you know, so you're getting these waveforms first, you're cupping the patient up, you're getting these first, and you see that, you know, the ankle and metatarsals are flat. I already know this is gonna be very hard if I hear anything at all, you know, so I'll give it a good shot, you know, trying to listen for dorsalis pedis.
Like you would try and listen?
I would try, yeah, definitely. You might pick up a little faint something, so you might be able to hear something even though you're not getting much of a tracing.
So that'd be like,
So if you,
like if somebody has this, they're not getting any flow. The immediate thought, like, is this something like urgent that you would be like, oh, call a doctor or something that you should?
Yeah, it's just that funny. Yeah,
Like,
sure.
they probably need an amputation, or we gotta get rid of it.
We gotta get them to surgery to try and either stent open those arteries or figure out what's going on.
Well, wouldn't it, if that's already been happening, wouldn't it probably at this point be like gangrene?
Possibly, yeah. Yeah,
Like if they already came in and it was already like that, we have.
depends how long, yeah.
But.
Yeah.
Some stuff we don't know.
Yeah, you'll start seeing it. Yeah, you'll,
yeah,
when you get into the hospital, you start seeing it. So yeah, so you give it a good attempt. And then if I still can't, you know, find it with this exam, I might grab the ultrasound machines, just ultrasound over the vessel to just show that it is occluded, and add some ultrasound pictures to that study as well.
oh, you can do that.
You can do that, yeah. Yeah. So this was just the interpretation. So again, bilateral low amplitude loss of dicrotic notch in the high thighs, bilaterally show aortoiliac disease, significant low amplitude waveforms at the calf. You know, indicates that there's multi-level disease, and then flattened at the foot. And no pressure ABI information except for brachials.
Is that an anacrotic notch? Oh. Not that one. Wait.
Kind of looks like looks like it's flipped.
I'm talking about that one. We went to the next one.
Oh. Yeah. Looks like it. Yep.
Mm-hmm. What, radio?
Yeah,
Cause that's like very, very like obvious, it's not like just a little bit, like
Yeah.
the one example that we had, it was just like a tiny little.
yeah, it definitely looks like a peak waveform, absolutely.
Right on.
Right on. Yeah, did they say why they were here? There you go. That's the interpretation. Peak waveforms at brachial levels, what does this indicate? Raynaud's question mark?
Raynaud's disease, right?
Yep. Yep,
That's when
Raynaud's.
it's in, on top of PAD.
Yeah.
And they don't have anything abnormal lower, any other than this. Yeah.
Yeah. So ankle brachial index is abnormal bilaterally. Particularly, yeah, so it's worse on the left. The waveforms are really flat on the metatarsal. The left one is completely flat. Even the left ankle is almost flat.
Possible and then big jumps after that.
Yeah,
So multi-level disease and. Radiocalcinosis is like the.
Is our test gonna be like case studies of this?
it is. The questions that I'm gonna ask are more just recognizing which extremity. Abnormal versus normal, like kind of similar to what I gave you on the quiz. You're not gonna have to make like, diagnoses like this. Recognizing which side is worse. So if you can recognize which side is worse, which side has disease. Yeah, and the PBR waveforms. Yep.
Kind of like last test.
Yeah. These all look normal.
They should have waited so we could see it maybe. Yeah, I would say they hold.
Yeah, those all look normal. The only thing they were questioning was like the high thighs being less than like 1.2, but that just might be the limb circumference. It's most likely normal. Yeah, because everything looks pretty normal. Interpretation. Case studies.
Yeah, we just.
Yeah, no.
No, that's what it's really about.
Yeah. Yeah, so this, yeah, we're gonna do this last one. So this is invasive. Nine.
They're still on Zoom.
Yeah, they're just quiet. Cyrus there.
Who's on there?
And Jess.
Is that Sarah? That's showing face.
I didn't realize that that was a college policy, actually, that we cannot require the students to turn on their cameras.
Stop, our teacher used to make us, but he wouldn't show his face.
He wouldn't show
He
his.
wouldn't show his, but he would make you show yours, and he would. So, yeah, it would be so annoying.
I didn't realize that till recently. No, I know you're there.
But my 3 kids might pop in the screen.
Yeah. Hi.
Oh, who's that?
This is Reese.
Is
She's dressed up in her
So this is not mine.
ballerina outfit.
It's not mine.
She's so cute.
It's Sissy's.
She wanted to come to class. Why'd you bring
Man.
No thanks.
her?
My son's back there.
He looks bored.
Yeah, yes.
Aw. Mom, when's this gonna be over? You're killing me.
I told him to work on a math workbook and he said no. I said that was enough. Anyways, I'm gonna mute now.
Coming through the. Let's just come. Um.
Is that all the PowerPoints?
Just this last one. So going through some invasive tests. So this is just touching on, so we talked about, let me just share this again. There we go.
Is this uploaded? This week? This one?
Um,
I could find it. That's all we have.
I know, it should be on D12. No. Let's see, table of contents. Sorry. This was the final one. So week 8 and 9 were like midterm and PVRSLP competency. Let's see what week 11 is. Yes. And then I took just like the physics stuff. We're going to do that next semester because you don't really need to know that now. At least it'll be fresh in your heads once you're going into your physics for fall or spring. All right. So there should be now on D12 week 10 if you want to.
So 8 and 9, we pretty much, yes, you're not. So for 8 and 9, we pretty much are, we already kind of.
Yep.
Oh, this was not too bad, only 94 slides. Honestly, it's just a number of slides. If you put a ton of information on like 80 slides, it still wouldn't look as bad as 100, like 50 slides. Just like they don't worry, it's scared.
I know. All right, so now these are just some examples of invasive arterial testing. So we talked about indirect testing. So that's our PVR, SLP, our pulse volume recording, plethysmography, our ankle brachial index. Indirect, these are examples of indirect testing because we don't actually image the vessels themselves. We have direct testing using our ultrasound machine where we can actually get a picture of those images. So ultrasound is nice because it's considered non-invasive. You know, we don't have to inject anything into the patient in terms of contrast to be able to get the images. We don't have to enter into the patient's body. But we do have invasive arterial testing, and the most common being angiography. So angiography utilizes an X-ray. So it's a specific form of X-ray referred to as digital subtraction X-ray or digital subtraction angiography. And we're able to utilize X-ray to image the vessels, but we have to introduce contrast into that patient. So it's now considered an invasive procedure because we're introducing something into that patient. So it is the gold standard when we're talking about imaging vessels, whether it's arteries or veins, because it provides a very detailed anatomy picture of our vasculature. So we get very good images of all the collateral vessels that are involved. We can see all the branches, tributaries. We also can do this angiography in essentially real time as we're imaging, you know, the contrast opacifying and filling those vessels. We can use angiography to also track our catheters to ensure that we're in the exact place where that disease is when we're doing some of our invasive procedures. So it's also, you know, a roadmap or a guide for those surgical procedures or endovascular procedures. The contrast media that we use, we typically use some, an organic iodine solution or a non-iodine solution. This organic iodine solution is what's called nephrotoxic, so it can affect your kidneys or damage your kidneys. So patients who have renal disease may not be a candidate for angiography procedures that utilize these contrasts. So we have to, you know, assess a patient's renal function prior to doing these tests. Also, patients might have allergic reactions to some of these contrasts as well. So this is just showing now the imaging device for a patient who's undergoing an angiography. So it's essentially an X-ray camera. So we have our X-ray source coming out to that receptor of that camera. So in order for us to get this contrast into the patient, we will typically perform what's called a catheterization. So this is the preferred method for us to inject contrast into the patient. So we reduce the likelihood of that contrast going to other places. So we just, you know, try and inject it with a straight needle into the vessel to introduce that contrast. There's a potential where the contrast might leak out of that vessel itself, or the vessel itself might start to leak. With catheterizations, we can reach almost anywhere in the body necessary in order for us to do selective injection of that contrast. Patients can be positioned as needed. The catheter can be left safely in that patient. So once we have access into that patient's vascular system, that catheter gets left in place, and we can have repeated access into the vessels and get to where we need to go to either perform the procedures or, you know, continue examination. Sorry. Hello? Hi, I'm just in the middle of class. All right. Sure. I don't know. I have to look. All right. I think back. Hey. Good timing. So we were just going through some case studies about like PVRSLP, just kind of recognizing again normal, abnormal in terms of like the pressures and stuff like that. I talked a little bit about a term acceleration time. I can explain that to you. It's really not hard to understand, but so we're just kind of getting into the we're just starting our last lecture topic. So these were invasive arterial tests now that we're starting to discuss. And I was just getting into the first one with angiography. So they're considered invasive because we're introducing contrast into that patient. So anytime we have to introduce something into the patient, it's considered invasive. So angiography is our gold standard, utilizes X-ray to image the vessels. So there is ionizing radiation, but we need that introduction of contrast to be able to visualize those vessels. So without that contrast, we don't see vessels on X-ray. And the best way to get that contrast into the patient is inserting a catheter or having the patient go through a catheterization procedure. So with this catheterization, they're going to introduce a cannula with the needle gets advanced into the patient. And then they can insert and slide the catheter through that guide, and the catheter and the guide wire remain in the patient while the procedures are being performed. All right, so angiography. So the main form of angiography is referred to as digital subtraction angiography. So with this, it allows the doctors and the technicians to have real-time imaging for our vessels, because the computer subtracts earlier images from the images, the image before from the current image, and creates almost like a cine loop, and allows us to image and perform our examinations in real time. So the benefits of this digital subtraction angiography, it's less contrast that's involved, and we can see things in real time. So these are just some pictures now for angiography. So again, you can see it gives you a nice clear image of the vessels, all the collaterals. So digital subtraction angiography utilizes an X-ray tube. So it's a single frame or single image or single area that we're imaging. We can also do this using a CT scanner. So the CT scanner now utilizes an X-ray, so it's radiation still, but that tube rotates around the patient. So with the CT, we can also get images of the structures around the vessels themselves. So it's commonly used for things like the brain, the abdomen, spine, neck, chest. We can use it for musculoskeletal system as well. So it's very good in evaluating a lot of the pelvic vessels, aneurysms, again, looking at the brain. So with that CTA, again, we also need to utilize contrast to image those vessels as well. So again, patients who have that poor renal function may not be a candidate for this. So that's a consideration. Also patients who might be claustrophobic, though now the CT scanners are typically more open than they were in the past. So a lot of this is kind of older information in terms of the CT imaging. So most of the CT scanners now utilize this helical or spiral approach where the patient's placed on the table and they just slowly pass through that CT scanner in and out, rather than using this step sheet approach. So this utilizes much less radiation, rather than having to continuously, image and then advance the table in small little increments. I'm trying to get to some pictures. So with our CTA, when we're doing imaging the vessels, we can also see a lot of the surrounding tissues as well. So we get that nice CT image with vessels nicely highlighted. So here's like a nice volume rendering. So you can see the vessels. So the CTAs are very critical when we're looking at the lungs in particular to rule out pulmonary embolism. So when we really want to rule out and we're worried about pulmonary embolism, blood clots that have traveled to the lungs from the venous system, the CTA is the gold standard for ruling out pulmonary embolism because we could see all the vasculature of the lungs at this point. So this is, again, CT is utilized, in places where, ultrasound really isn't going to be, effective. So again, we might have a lot of bowel gas obscuring our images for our vessels in our abdomen, vessels of the brain. It's obviously the lungs, because we can't scan the lungs because of the air in the lungs. So when we're looking at these angiograms, whether it's the CTA or the digital subtraction angiography, are you guys familiar with the term opacification? Have you ever heard that term, opacify? So opacification refers to the filling of a vessel with contrast. So when something opacifies, it fills completely with color. What's my way? So we'll have our vessel. We'll fill it with contrast. So we'll introduce contrast and we'll pick up that contrast within that vessel, causing that vessel to light up. So if it completely fills up with contrast, that refers to being fully opacified. This is fully opacified. So if there is some sort of blockage or something in that vessel, when we see it, that area that's blocked, like this, will not opacify with color. So it might be partially opacified. So when that contrast is introduced now, we'll see partial filling of that vessel. So that area would be referred to as partially opacified. If a vessel, is completely blocked or occluded and no contrast gets through into that segment, the vessel will be considered, non-opacified, or there'll be non-opacification of that vessel. I'm trying to show like a nice picture for that. Saw one here. So here we can see this filling defect. So here we see the vessel nice and bright, filled up with color, so it's considered opacified. And then we get a segment where we don't see any contrast, or maybe a little bit of contrast getting around that, and then it fills up with contrast again. So this is referred to as a filling defect, and that segment of vessel is non-opacified. It didn't opacify, it didn't fill up with contrast. And that's how they're able to read these exams, to determine where there's blockages, where there's stenosis is, if anything's occluding the blood flow. So some limitations for that CTA, again, if they're allergic to contrast, if they have any sort of renal function problems, we can't use the contrast. So both angiography and CTA, we need that contrast in order to be able to image these vessels. Unfortunately, they cost more. Typically, they're more costly, than doing an ultrasound. So in terms of cost effectiveness, ultrasound is more beneficial. We do have an option, if say a woman is pregnant or they can't be exposed to ionizing radiation, we could potentially do an MRA. So using a giant magnet or using an MRI machine, we could also do an angiography exam. So the good benefit about an MRA is it can be done either invasively with the contrast or non-invasively, so we don't necessarily need that contrast. We will get better images with the contrast, but it is not absolutely necessary. Has anyone had an MRI? Have you ever had one? Yeah. So no. So MRIs, they take a very long time. They're very loud.
Terrible. They forgot about me. I was moving for 3 hours.
3 hours.
Yeah. Like the nurse came in was like, sorry, we completely forgot. It's like,
so you have to be, they're very sensitive to motion. So, part of it is you have to be very, very still. So you can't move, that'll disrupt your image. They take a very long time. Can't
close your eyes.
So
yeah, they're like just taking that. Easier stuff.
In addition to that, since it's a very large magnet, anyone who's had any sort of metallic implants, certain, cardiac devices like pacemakers, defibrillators, you can't go into an MRI machine, surgical clips, aneurysmal clips, IUDs, artificial joints. Yeah. So it depends on the IUD. So,
it's not strong enough on the table.
There's like 1.5.
Yeah, what does it do though?
So like the 1.5 is like a less strong magnet. And if you have like the aneurysm, but we're looking at your thighs or something, then they'll be like, that's cool. If it's for your brain, then you don't have it.
Yeah.
What does it do then? My dad has like metal rods in his arms because he used to play hockey.
Yeah. So
He like broke everything.
that might not be.
So, but he's never had. You just don't do it. Yeah, but like, but what happens?
They also like tattoos they have to cover because we have to ask that when I schedule them. And then if you have a tattoo, because there's like little metals in the
Certain.
and
Yeah.
so you can still get it done, but you like it might heat up from the magnet, so they have to put like stuff on you like to cover it.
Is MRI and MRI the same thing?
Yeah, so MRI is angiography. So we're looking at the vessels using an MRI machine.
Like
So this is angiography, imaging the vessels using an MRI machine. So that's what MRA is. Yes. So we're using an MRI machine to image the vessels. So since it's the vessels we're focused on, we say angiography, magnetic resonance angiography.
So the same test, but the MRI is
because we're looking at the vessels. Yes. So it's just the MRI looking at the vessels. Yes.
They see like can't they see like tendons?
They can. Yes. Yep. With those, they typically don't do contrast for looking at the tendons and ligaments. Yeah, they just put you in there. So that contrast helps to really, make those vessels stand out. So get a good, clear picture for the vessels. I mean, like we said, we can do it without the contrast, just the image isn't as good. So here's just showing, yeah, so like an MR with the brain, like with the contrast.
Like by me, there's a little black hole in it. That's the
Yeah. So they're trying to time the contrast as it passes through the body. So they're trying to capture that image at the exact moment where that contrast is kind of, yeah. procedure. All right. So again, patients who are claustrophobic, can't lie still. MRIs are very, very costly.
And they're really gonna be good.
Booking an appointment for one, yeah.
You have to go through like 5 doctors before you they'll like schedule your phone. Really? I did. I don't want to do it today.
But the CT, I got a CT and that's forever.
Mm.
My brain. It's had a lot of concussions.
A lot of concussions.
Yeah, over 10.
You got 10 concussions?
Oh, wait, yeah.
From what?
And when I was young, I got them when I was little, they got that, and they got.
Oh my goodness.
That's why I went to AI. So I have a concussion back.
Just pull out the most important things for you guys. All right, so in terms of invasive procedures, we have angiography, X-ray, radiation, contrast, CT, or CTA, computed tomography, angiography also uses X-ray. So it's multiple X-ray shots now. So it's much more radiation than a typical angiography. So in terms of levels of radiation, CT is significantly more than an angiography. That also utilizes contrast. MRA utilizes the MRI machine, which is a giant magnet. So there's no ionizing radiation involved in that. So that's benefit. But again, there are the limitations. The metal issues with metal, claustrophobia. With the MRA, we could use with or without contrast. So that is a benefit of that as well. So it can be done non-invasively. Nuclear medicine is another type of imaging modality. So I didn't know too much about nuclear medicine until before coming here, or when I actually shared in my office with one of the nuke med procedures. But they inject small amounts of these radioactive substances or isotopes into the patient as a tracer. So it's either given orally or injected or even inhaled. And they use a special gamma camera to image the radioactivity emitted by that patient and those selected body parts that they want to evaluate. So they look for functional abnormalities. So the most common use for us for vasculature, when we're talking about nuclear medicine, is an exam called a VQ scan, or ventilation perfusion scan, that shows blood flow and air movement in the lungs. So this is something that we utilize when we're worried about pulmonary embolism as well. So this used to be one of the exams that they would often order when they're concerned about pulmonary embolism or blood clots in the lungs. So nuclear medicine can also be used in stress tests for cardiography. So that's another common practice for you guys. So for CVS, you guys are going to actually be one of the required observations is to go to see a nuclear stress test. So with this, they can also image. They have the patient, they inject the radioisotope, and they can see perfusion of blood flow in the heart and determine areas that might be infarcted or not having adequate blood supply. It can be used for bone scans, PET scans, assessing the liver, spleen, gallbladder, kidneys to evaluate organ function as well. It's used in thyroid scans as well. And then we also have PET scan. So this is positron emission tomography. So this falls under nuclear medicine as well. So this is just showing some of the images now that you would get from a nuclear medicine procedure. So limitations. So it's certain patients it's not suitable for. So women that are pregnant or nursing, certain medications might affect it as well. And that radioactive uptake may take as long as 48 hours. So these patients are injected with these radioisotopes, and then they come back later to have their actual scans done. So there is a certain time that you have to wait. I have to learn how to talk to the nuke med teacher about trying to read some of these scans. So she was basically telling me like, yeah, they show up as like hot and cold spots based on like, how much of that isotope gets uptaked. So they can determine, like areas of either bleeding or increased vascularity, which could potentially indicate, active tumor growth that has increased vascularity to it, areas of bleed. So now they have PET CT or fusion imaging where they combine CT scans with the PET, the nuclear medicine procedure part of it, so they can get a good picture, of what's going on inside that patient. So it's particularly useful when they're diagnosing cancers.
Contrast CT and used CT or PET. Is it because they use different types of isotopes, or is it because
those two are combined?
Oh, so yeah, so they combine a CT scanner with that PET. So it's a PET, it's a special scanning.
Oh, this is CT and PET.
Combined creates that fused, yeah.
So that's part of nuclear med, not us, right?
Yeah, it's nuclear med,
We
yeah.
wouldn't have to like,
No, you would
like if they came in with this and like, I'll do an ultrasound, this showed this, we wouldn't need to understand like what we're looking at on that.
You can ask a doctor how to look at these things, to be honest. I mean, I started like with COVID, they would do a chest x-ray first. So I wanted to like kind of get an idea, like, all right, what am I looking for a COVID positive lung, like, so like before I go and do the ultrasound, like, is this patient probably have COVID yet? Because at that time, the tests were taking a long time to come back. They didn't have those rapid,
You were still working like in the hospital then?
Oh yeah.
In New York?
Oh yeah.
So it was rampant over there.
It was a nightmare. It was a war zone.
Yeah. Even ultrasound like here. Well, it's crazy in here, so I couldn't imagine.
Oh yeah.
Highly, yeah.
Like picture Christiana, but like patients everywhere. So in the cafeteria, the library, we just turned it into patient triage rooms. The parking lots, we had pop-up tents where patients were coming in, we're doing exam, wheeling machine out to the parking lot into the tents. Like
the first year, like your first year on the job was COVID, like as an ultrasound.
yeah, that's crazy.
That's crazy.
Yeah, it was nuts. And we had no idea what we were doing. I remember like it was like overnight. Like we had one patient, two patients, and like I was working evenings and like they would just take the patients to do their tests. And then all of a sudden, in a matter of like a week, it just blew up and like everything was just shut down. So they shut down all the outpatient offices. So like I had friends that were, doing ultrasound in outpatient offices, and they put them just into the labor pool. So they were doing things like just like wrapping dead bodies and like going into the ICU and turning patients all day long, like it was just.
They weren't even doing like the actual job.
They're just
doing different things. Yeah. Yeah, whatever. Yeah. So I was like, I mean, that lasted for about a week, and our supervisor, she was awesome. She was like, screw this. I'm not subjecting you guys to this. So she changed all our schedules around. So she made us all do 13-hour shifts, and like we had day and evening crews. And so like, it was like, we'd only work 3 days a week, 13 hours. And like she pulled all those people in. We're like, all right, you're just gonna work in the hospital from this time to this time. And so we were just going portable all day long, because like patients weren't coming to our department at that time. So all our room machines were now portable machines, and we were just going around to all the ICUs, and everyone was in the ICU. It was nuts. Everyone was dying. It was, oh man, it was crazy.
Crazy how it's 3 years.
Yeah.
like a couple months ago. Just happened.
Yeah. It was nuts. And yeah, it felt like a movie. It was weird. Nah. Yeah, we had.
Yeah.
I know. Anyway, let's see, what was this? So this was So ultrasound usage in emergency situations. So again, we're ultrasound. So we have the benefit of being mobile, being portable. We can be, easily accessible. So like we can get to a patient relatively quickly. We can bring the exam to them. So sometimes, delay in ultrasound in critical care can, be the difference between life and death, limb preservation or loss. So exams that are stat, I want you guys to really treat them as stat and be able to learn the differences of what, constitutes urgent and emergent findings. So when we're talking about lower extremity ischemia, so acute ischemia would be all of a sudden, the patient all of a sudden doesn't have any blood flow to their leg. It's usually caused by some sort of embolism coming from the heart that gets lodged in a vessel. So this was just showing some of the upper diameter measurements, also when we're detecting aneurysm. So some of the acute limb ischemia could be due to either aneurysm of that vessel and then a piece of that thrombosed aneurysm may be lodging off. So this is just kind of a good rule of thumb when you're looking at vessel segments. So 1 centimeter for common femoral artery, 8 millimeters for SFA, and then half a centimeter or 0.5 centimeters or 5 millimeters for popliteal artery. So typically when you get over those measurements, you worry about aneurysmal or consider aneurysm. So when we're looking at doing an ultrasound follow-up, maybe for an abnormal segmental limb pressure, again, the disease segments can be proximal to that abnormal pressure segment. So we want to start imaging proximal to that. Thrombosed arteries, you can track a thrombosed artery using the accompanying vein as a landmark as well. So just remember those arteries and veins course side by side. So if you can document the veins, you can use that as a landmark for the artery as well. So this was just showing a popliteal artery aneurysm. So very, very large, where they measure 2.76, so almost 3 centimeters in diameter. So almost 3 centimeters, so 2.76 centimeters. So that's like size of aorta, like in terms of diameter. So that'd be wider than most people's aorta. It's in the popliteal artery. You guys remember the correlation? If a patient has popliteal artery aneurysm, what could also potentially mean? So there's a correlation between popliteal artery aneurysm and abdominal aortic aneurysm, so AAA. So you guys in DMS, you're going to learn all about AAAs. Like that's the big thing. Like everything is an aneurysm or a dissection, or like patients coming in with like back pain or abdominal pain. Like, oh, it could be an aneurysm. Doctor, you get some ambitious like first year resident that thinks everyone has an aneurysm, and you get all these abdominal studies. So this is just, again, recognizing now your arterial waveforms. So here we have an arterial waveform. So we're above the level of that blockage. We're seeing high impedance. So something is impeding that blood flow. So it's very high resistance. There's no diastolic component. The waveforms are kind of diminished, the velocities. So it's a low velocity. Just above that blockage or occlusion, we can see that systolic thumping. So those little blips now. This is a good example of that systolic thumping. There's a little bit of blood flow getting through. So if we were to then image the vessel further down, we for sure have our nice tardus parvis waveform. So a very slow upstroke. Was it your class when I was describing tardus parvis, like, and resistance to blood flow? I don't think it was you guys as a open house party. No. All right. So this was kind of funny. Like I came up with this like when we were discussing with the second years, so they didn't really understand the whole idea of peripheral resistance and like diastolic flow and flow volumes and all this. So I kind of made up like this idea like that helped them to kind of grasp it, that like so like you have a blockage in your vessels in an artery or something like that. So there's a blockage, blood flow is not getting down to where it needs to go. So say like there's a blockage in my thigh and my calf needs blood flow. So the muscles of my calf, the vessels in my calf, they're controlled by those arterioles that have the smooth muscle fibers on them. So since my calf needs blood flow, the body's going like, oh my God, like I need blood flow. What can I do? And the body's natural response to that is it's going to dilate those vessels. So I kind of think of it like, oh crap, I need blood flow. So what can I do? My arteries are going to dilate. So when those arteries dilate, it's now like, you know, a free for all. So it's like my calf is going like, hey, I got a party going on in here. Who wants to come? You know, like, so like the vessels are going to dilate. It's going to be a free for all. It's going to do whatever it can to get blood flow into those vessels. So it's lowering the resistance. So it's kind of like the bouncer at the bar, letting everyone in now. So it's like they want to get as many people into that bar to crowd up that bar. So it's going to relax its restrictions. It's going to be less restrictive as to who gets into that bar. So it's going to open up the arterioles are going to dilate. It's going to open up. It's going to lower the resistance of blood flow getting to that tissue bed because it needs blood flow. There's a blockage here. It's preventing blood flow from getting down. The lower down segments need that blood flow, so it's going to become less restrictive. The arterioles are going to open up, dilate, and that's going to lower the resistance to the blood flow getting to that vascular bed. So if that's why our peripheral vasculature, you know, the muscles have high resistance, is because we don't always need that blood flow. So that blood flow is better served going to your brain. It's better served going to your organs, to your kidneys. So those arterioles are going to constrict and prevent a significant amount of blood flow from getting to your muscles because it really doesn't need it right now. So that's why when you exercise, they dilate, bringing blood flow to that to those muscles that are being used. When it's not needed, they constrict. So that's the whole reason why our peripheral vasculature has high resistant blood flow. It's because of those arterioles, you know, doing their job, either limiting blood flow or promoting blood flow to that tissue area. Pseudoaneurysms. Yeah, we've been talking about pseudoaneurysms. So yeah, most common cause of pseudoaneurysm is due to some sort of procedure, or is due to a catheterization procedure when they go into the groin. So it's some sort of percutaneous arterial catheterization that occurs at the puncture site. So we see that characteristic yin and yang sign. When we Doppler that neck, we have our characteristic bidirectional to and fro flow. So Brian, who's in there now, just came back. He's like, Dan, I saw a pseudoaneurysm. And he like took some pictures for the flow. Like, I don't know if he should have done that, but like, yeah, had some pictures on his camera just showing it was de-identified there. So there was no patient information, but he was very proud, and he's like, yeah, I saw the bidirectional flow. They measured it, you know. So he saw his first pseudoaneurysm. So just recognize that pseudoaneurysms can also be multilocular or multi-lobed. So they can have multiple areas or multiple hematomas that are bleeding, connected by individual necks. So your native vessel down here, neck going into maybe a small little one here, another neck going into another pseudoaneurysm, another neck going into another pseudoaneurysm. They can have multiple necks. So in terms of thrombin injection, again, so thrombin is that medication that's going to instantly thrombose or clot off the pseudoaneurysm. So we prep the area that's going to be injected with betadine to sterilize the area. They use a sterile drape cover to cover the area. A thin needle is used to inject the medication as well. Probe covers are utilized over your transducer. So when you're imaging, you're going to put on sterile gloves yourself as well if you're assisting the the doctor with the injection themselves. So this is just showing again the needle tip with that thrombin medication in the actual pseudoaneurysm itself. So you want to make sure that again that needle tip is as far away from the actual neck as possible. They inject the medication, it thromboses instantly. And then you're going to require a post image showing the native vessel with still blood flow in it and the completely thrombosed pseudoaneurysm. So typically you're going to either do a cine loop clip, so you'll record a clip of you kind of scanning, maybe transverse superior to inferior over that hematoma that's now thrombosed, just to show that there's no blood flow in it now. Or you might just take some representative images as you scan through it. Traumatic arteriovenous fistula, we said could be due to some sort of either penetrating injury. So again, cardiac catheterization. So it's an accident, maybe they tried to get into that artery, went too far, punctured all the way through the artery and then into the vein itself. And since they're in close proximity to it, that blood flow from the artery is going to try and, again, find that path of least resistance. It's going to find a channel into the venous system. It could be, again, also due to some sort of physical trauma. Large fistulas can result in digital ischemia. So we said a patient, if they've have an AVF that been created for dialysis, if the AVF is too large, it can lead to ischemia in the hand, so not enough blood flow getting down to the digits. On the other side of that as well, too, we now have all this arterial blood flow going directly into the venous system, and it's a very high volume. So now we have all this blood flow that, is going right back up to the heart. So it's going into the arterial system, then getting quickly diverted into the venous system, and then returning back up to the heart. And that could potentially lead to heart failure in certain patients. So we're overloading that right side of the heart. The things we feel for are that palpable thrill. So again, that word association, AVF, arteriovenous fistula, palpable thrill. That palpable thrill is that anastomosis, that connection between that artery and the vein. We see increased arterial flow. So before that fistula, we have increased flow volume. We also have decreased resistive index, or RI, because we have more diastolic flow, because that blood flow is going into that low resistant venous system. In the venous side, we have high velocity pulsatile venous flow now. So it's that mixed signal between arteries and veins. Do that too well, huh? Anyway, so above the anastomosis, we see, high velocity, low resistant flow. And then in the venous side, we see high velocity pulsatile flow. Again, if we have penetrating arterial trauma, this could potentially create an arteriovenous fistula. So for scanning patients that have, any sort of these penetrating injuries, so maybe like a gunshot wound or stab wound, and they worry about damage to the vessels, we have to ensure that we're utilizing sterile technique, either dressing, probe covers, or sterile, and utilizing sterile gel. So we want to inspect, the area where the injury is, assess for either absent flow or disturbed flow, or maybe flow that's leaking out into the body compartments. Good. Hopefully they're medicated. That's another thing I forgot to mention too, is sometimes you'll be trying to do an exam and the patient's in too much pain. It's okay to request, that the patient receive some sort of pain medication prior to coming. So, if need be, and you need to get this test, if it's critical, they may come down. I've had nurses come from the ER and administer a little bit of morphine, give them a bolus of morphine in order for me able to do an exam. So I've had patients then go to the room and then come back later once we've even had to sedate patients. So like, in order to do certain exams. Like I remember I had this one doctor, like he was a little annoying. Like we would do pediatric testicular exams, like to rule out torsion for the testicles. And in peds patients, it's difficult because they move around a lot. So like, I don't know if you guys ever noticed, like if you're trying to Doppler and the patient's moving around, trying to Doppler a vessel while they're moving is almost impossible to get a good tracing and waveform. And like, I could tell looking at it that it wasn't torsed. I could see live, like, getting color flow in the pictures, but he wanted a waveform tracing and like a Doppler waveform, like of this little teeny artery within these little teeny testicles, it was just, he would actually have the kid, we'd have to wait till the kid either fell asleep and try and do it, or give him Benadryl or something like that, to try and come. It's crazy. It's like doc, it's not forced. Yeah, it's not necessary. I know, but it was, that was the thing. He was worried about a liability thing.
What if you have a patient who's
the parents could have refused, no, this is ridiculous. We're not.
not compliant, as in they just don't want to put up with it if it's an adult.
If it's an adult, well, adults can usually stay still.
No, I mean non-compliant, you're doing something and it's uncomfortable and they're like, no.
No, they refuse. Yeah, you just document, you stop. So you don't, if a patient tells you to stop, you stop.
Oh, yeah, I mean a doctor,
and the doctor insists. I've seen doctors and insist. I remember I had one patient, he was refusing, and I called the doctor to let him know that they were refusing the exam. And doctor's like, put him on the phone. So I'm like, doctor wants to talk to you. And they're like, no, yelling at the patient, no, you need this test. And then I get the phone back, hi doctor. It's yeah, he's gonna do the exam.
That's what I mean. Sometimes people get doctors will get mad and
they do. I've experienced it, yeah. So then as long as the patient
mad did you hear about when we were talking about headbutt? Man, about something.
Yeah.
Just
tell me.
Real bad.
Yeah.
Yeah. I mean, you as stenographers, well, you can explain, the importance of the exam and, why it's important, and let the patient decide, if they have the capacity to make their own decisions too. I've encountered that too. I thought the patient was completely, lucid. And then I come to realize they had altered mental status, and they, were dementia patients. And I was having a nice, lovely conversation with them, I didn't know, And I'd be I'll call the floor, patient's refusing this exam. They don't have that capacity to make that decision, so they have a healthcare proxy or someone else, making the medical decisions for that, so
Go ahead with it there.
Yeah, so as long as I have consent from the family member, then it's okay to do, whatever. Yeah.
So what if you have a patient who's non-compliant, you can't, even though they have some.
If you can't, and then they're not compliant, they're combative, they're just combative, and they're fighting, and then you just unable to perform exam due to patient, being combative, or you'll get those. Compartment syndrome. So we discussed a little bit about compartment syndrome, right? You guys remember a little bit? Talked about it briefly. So compartment syndrome. So with this, this is a result of some sort of blunt force trauma. So when you think compartment syndrome, think motor vehicle accident. That's going to be one of the main ones, or some sort of trauma to an extremity or a limb. So with this trauma, that limb or extremity swells up, or that muscular compartment swells up. And then that swelling is actually enough pressure to occlude the vessels. So if the pressure gets high enough and swells up significant enough, it's enough pressure to actually compress those vessels, the arteries and the veins, and prevent blood flow, particularly in the arteries, from getting past that compartment down the extremity to wherever it needs to go. So this could be, a critical situation that could lead to potential limb loss if that segment is ischemic for a significant period of time. So this was just demonstrating the asymptomatic versus the symptomatic leg. So above the swelling compartment, they noticed that the waveforms were diminished in flow, very high resistance, so meaning that blood flow was meeting up against something that was stopping it from flowing. And then below that level of the compartment that was swollen, we have very low resistant flow because that vascular bed, again, is starving for blood flow. Those arterioles have dilated to try and get that blood flow into that tissue bed. So we can notice very different waveforms above and below that compartment that's swollen. We would also try and image the vessel within that muscular compartment to show that there was absent flow as well. So kind of missing from this picture is the vessel segment within that swollen compartment. Just keep in mind, if it's significantly swollen, it might be difficult to image that vessel as well. So maybe they couldn't see that segment of vessel within that swollen compartment, and they're just seeing above and below it. And then comparing to the asymptomatic leg, where we see a nice triphasic normal looking, arterial waveform. So that, could be enough to make that diagnosis of compartment syndrome. This just was talking a little bit about graphs, flow volume and graphs. So if the patient has an arterial bypass graph, I think I had said less than 35 last time. But the main things for bypass graphs when we're talking about stenosis is elevated velocities over 180 or very slow velocities, slow flow within that graft itself. Indicates, impending graft failure. So those are the real main considerations. Within it.
In the next class, we're not doing the written, right?
No.
It's just like review the final. Oh. So like 8 o'clock lecture.
Yeah.
The rest is just all review.
Yeah.
We'll be waiting for them. Yeah. Did an exam
And then review.
Yeah, so basically for the exam, I want you to just, for these invasive testing, like I said, angiography is that gold standard. So digital subtraction angiography utilizes X-ray. You have to utilize contrast, so it's invasive. CTA is similar to the digital subtraction angiography. The CTA just utilizes a CT scanner now, so it's still X-ray, so it's still radiation. You still need the contrast. Contraindications for those are both very similar. So they both utilize radiation. Patients who have poor renal function, we worry about the contrast affecting the kidneys. MRA can be done invasive or non-invasive, so we can be done with or without contrast. Utilizes an MRI scanner, so it's a giant magnet, the MRI machine. The limitations with that, it's very costly, time consuming. Patients who are claustrophobic or unable to lie still. Also patients, again, with any sort of metallic implant devices, anything like that. The nuclear medicine procedures utilize radioisotopes. So this is invasive because we have to inject those radioisotopes into the patient, either inject or ingest. And then some of the capabilities for that. The most common one is this VQ scan, the ventilation quotient scan. We'll discuss this a little bit more next semester when we talk about the venous side, because that is particularly used again for assessing for pulmonary embolism, blood clots in the lungs. So that kind of ties into the venous side. So PET scans fall under nuclear medicine. So those PET scans create functional images that show blood flow or areas of high metabolism. This also cannot be used for pregnant women. And then PET CT, or referred to as fusion imaging, combines those PET scans with the CT scanner. What else we discussed? Let's take a look at the quiz.
You said those SMB studies right for those.
That's more for the final. So what test is often used to see if a patient has a complete or incomplete palmar arch? Allen's test, yes.
Oh, last week, right?
Yeah, I think it was last week. So Allen's test, so no, the Allen's test, what incomplete versus complete Allen's test would look like when we're assessing the palmar arch. So like I have an example, like of a study below, does the patient have a complete or incomplete palmar arch? So like with the PPG tracings, when we have the sensors, if you compress the artery and it goes flat, they have an incomplete palmar arch. But if you maintain your waveforms, then they do have a complete palmar arch. With the ultrasound, so be able to understand, like, you know, if I'm Dopplering the radial artery and I do radial artery compression, if it's complete, then it should be reversal of flow. So if I'm Dopplering here and I'm compressing, you know, the radial artery, if patient has complete palmar arch, I should get flow reversal because it's coming around the ulnar and then around that superficial palmar arch back towards the radial artery. And if I'm Dopplering that radial artery, I should come on camera, right? So you guys see me, and I'm Dopplering that radial artery, and I'm compressing the ulnar. That waveform should get larger or augment because I have increased flow from that radial artery, then perfusing the rest of the hand. So those were the two examples that we went over. Like if you're able to understand that,
Push on the ulnar, the waveforms increase.
On the radial, for the radial. So if I'm listening to the radial and I compress the ulnar now,
Okay.
the hand's gonna be like, hey, I need more blood flow, you know, right? All of a sudden the ulnar got cut out. So again, what can I do to get more blood flow to that hand? Let's increase flow. Let's dilate and expand, you know, the arterioles and let more blood flow in via that radial artery. So we should just see increased flow in that radial artery.
No, that's part of the Allen's test, right?
That's part of the Allen's test. If you don't, then yeah, it's correct. So if that doesn't happen, then the patient has an incomplete palmar arch. So if we don't see that flow reversal when we're Dopplering and compressing the same side. So if you Doppler and compress the same side, like, you know, we should see flow reversal for a complete palmar arch. If we don't, then it's an incomplete palmar arch. So our lab, we always check the ulnar as well. So we did the same thing, Doppler the ulnar artery, did compression of the ulnar, looking for that flow reversal, and then augmentation by compressing the radial artery. So we tested the ulnar artery as well. I want you guys to memorize the values for the diameter measurements for our vein mapping or our grafts and fistulas. The minimum diameter measurements that are needed in order to create a fistula. So these are diameter. Where am I? Diameter criteria. For VAS. So AVF, vein, it needs to be, what's it, right, doing that right, greater than 0.25. Centimeters. PVG or grafting. Greater than 0.4 centimeters. Then artery. Or AVF. Or AVG or graft. So just the artery has to be greater than 0.2 centimeters. So those were the three numbers that I want you to just to memorize.
Is it gonna only be in centimeters or are you gonna add millimeters to it? Because I could use it in the problem, you know?
Can you convert?
They're laughing.
Would it be millimeters would be just carried over one?
Yeah.
Okay. I like don't pay attention. I mean, it's
2.5.
Pay attention to units. Hint.
Wait, 2.5.
So if you're converting to millimeters, then so 2.5 millimeters, 4 millimeters, and 2 millimeters. Yeah. Do you know what that means? Kind of wish I had 1 week in the lab for us to start the legs before doing this. Because at least you can see the vessels in the groin. So there is one labeling picture for ultrasound, recognizing the vessels of the groin for that Mickey Mouse configuration. So, label Mickey Mouse.
Wait, we need to do that now? The test?
For the quiz, yeah.
Okay. There's something about that. I feel like we really good. We were regret it for the Tuesday. Yeah. We did.
That. But my picture looks terrible. That looks like that. So arteries and then vein. So the more superficial one is going to be your SFA. Your deep one is going to be your DFA, deep femoral artery. The vein has not bifurcated or split yet, so this is still common femoral vein. And then we have our GSV, or great saphenous vein, not even to that common femoral.
So once it does bifurcate, it's not gonna look like a Mickey Mouse anymore, right? It's not gonna just be like Mickey Mouse, like something mounted.
So this is still in the groin. So now coming more inferior or coming lower down the leg, this is eventually going to split now. So then your image is going to look more like, you know, artery and then vein and then artery and this vein. So, here.
So this is gonna be labeling bone line multiple choice.
Yep. Similar to the last test.
Labeling, any other diagrams you need to reveal?
It's matching. Like
Like a diagram?
like arterial stenosis to diameter reduction.
So like those values we just did, but like that would be the way you're doing.
Like this.
Just like looking at the waveform, identifying which description would best match.
Yes.
I was talking about anatomy.
Oh, anatomy? No, not yet.
Beginning. That's not good.
Yeah, sure. I was showing them this. I think you guys are gonna be in good shape. Yeah, that's it.
Otherwise.
No, I'm just I tricked them.
Stay here all day. We have nothing better to do.
See what's on.
50-50 last week in your speaks lecture, or like more so on this week.
It's about the same.
Yeah.
It's really not hard. You guys are gonna be like, this is a joke.
Last week's test was really good. It was great.
I stress out so much about that, and then
We ended up doing it together.
well, I could have done it on you.
Yeah.
Yeah, you all could have done it on your own. I know that.
But
I heard you guys all studying.
Yeah, we're all studying crazy. And you were like, yeah, that's good. And we shared with everyone. So they all have the same study guide. Yeah. Oh, I bet. How far in the 1 year is that?
I can't start my ethics at all, but I think I can figure that out. It's the
I don't know how to do a counter in the bottle.
like I thought that I did. I did four-minded pieces. I did not like it. The whole thing is social.
What do you mean by?
My thesis is right. But like the against me didn't have evidence except for the fact that there's like, you know what I mean? Like their best